Now we are going to discuss primary sclerosing cholangitis. Primary sclerosing cholangitis is asked in medicine, surgery, pathology and radiology. Very important topic. So primary sclerosing cholangitis. See, in surgery, most of the terms you can remember by dissecting the terms. So if you're going to dissect this term primary sclerosing cholangitis, what do you mean by primary? Here it means unknown etiology. So this primary means unknown etiology. Sclerosing means there is presence of strictures. So what? Multiple strictures involving both intrahepatic bile duct and extrahepatic bile duct. Clear? Involving both intrahepatic and extrahepatic bile duct, and there is recurrent cholangitis. Okay, so this primary sclerosing cholangitis, here there is unknown etiology, and we discussed this is more common in males. You have to remember, because this was asked many times. It is associated with HLA B8 and DR3, and all of you must be knowing that there is strong association of primary sclerosing cholangitis with ulcerative colitis. So it is associated with ulcerative colitis, right? Now see, if a patient is having primary sclerosing cholangitis, what are the chances that patient is also having ulcerative colitis? It is 70 to 80%. So there are two important statements. If a patient is having primary sclerosing cholangitis, there are chances that this patient is having ulcerative colitis in 70 to 80% cases. And if a patient is having ulcerative colitis, there are chances that patient is having primary sclerosing cholangitis in 5 to 6% cases. Now how to remember this? It's very easy. See, generally patient is going to develop ulcerative colitis first. Okay, and after 10 years of ulcerative colitis, patient is going to develop what? Primary sclerosing cholangitis. So if a patient is having primary sclerosing cholangitis, there are high chances that patient is already having what? Ulcerative colitis. And if patient is having ulcerative colitis, there are low chances that patient is going to develop what? Primary sclerosing cholangitis, right? So both of these questions are asked. Okay, and you have to remember, because they are going to ask the percentage. After that, you must be knowing that smoking is protective in primary sclerosing cholangitis, in ulcerative colitis. So smoking is protective in primary sclerosing cholangitis, ulcerative colitis, Alzheimer's disease and Parkinson's. Alzheimer's and Parkinson's, right? It doesn't mean that you should start, right? Because smoking is protective only in these conditions. Otherwise, smoking is a risk factor for most of the malignancies, and smoking is very dangerous, more dangerous than alcohol. So don't start. And if you are a smoker, stop it. Now see the pathophysiology. So what you can make out here, you can see that there are multiple strictures involving both intrahepatic and extrahepatic bile duct. Now see, this is the normal anatomy, right? So first question which is asked frequently, that what is the target cell of injury? The target cell of injury is the cells lining the bile duct. And what is the name of cells which line the bile duct? Yes, it's cholangiocytes. So first question, what's the target cell? Target cell of injury, it's the cholangiocytes. Clear? You know that in primary sclerosing cholangitis, there is formation of multiple strictures, and if there is formation of multiple strictures, you can see this kind of appearance is seen. Can you see this appearance? This appearance is known as what? Beaded appearance. So this kind of appearance, this is known as beaded or pseudo-diverticular appearance. You can find these appearances on radiology, especially cholangiography. If I'm going to take cut section from one site of stricture, so if you are taking cut section from the site of stricture, this kind of appearance is seen. And what is this kind of appearance? Yes, this is known as onion skin appearance. So on cut section, there is onion skin appearance. These are the questions which are asked in pathology. Now see, there are two kinds of presentation. Generally, patient presents in fourth decade, but before that, there is asymptomatic elevation of gamma glutamyl transpeptidase, right? So two presentations, either patient is symptomatic or asymptomatic. So if patient comes early and on laboratory investigations, it is found that GGT is raised. So two situations. One, there is asymptomatic elevation of gamma glutamyl transpeptidase, and the second situation, patient is symptomatic. Why? Because this patient started having recurrent attacks of cholangitis. Okay, so what are the symptoms, complications which are seen in primary sclerosing cholangitis patients? This is liver, this is gallbladder, this is bile duct. So because of multiple strictures, what there is obstruction and there is infection, that's what cholangitis. Because of stricture, there is stone formation also. So what? CBT stone. Because of these stones, there is obstruction of pancreatic duct temporarily, and this can lead to what? Acute pancreatitis. And the chronic inflammation which is going on in the bile duct, it increases the risk of which malignancy? Cholangiocarcinoma. Cholangiocarcinoma. Clear? So these are the complications of primary sclerosing cholangitis. So generally, patient is having recurrent attacks of what? Cholangitis. So we discussed what is the investigation of choice for diagnosis of primary sclerosing cholangitis. Since there are multiple strictures, obviously it is MRCP. But MRCP is purely diagnostic. So what is the gold standard investigation which can remove the stone, which can put the stent for strictures, and that is ERCP. So two questions, the investigation of choice for diagnosis, and that's MRCP, and gold standard investigation, and that is ERCP. So you can see this image, this is MRCP. Here you can see the basic framework of liver. You can see here what? Pancreatic duct. This is the bile duct, and here you can see that there are presence of multiple strictures. Clear? Right? If you see the intrahepatic bile duct, what? There is selective destruction of terminal branches. So the branching pattern is reduced, and this kind of appearance is known as pruned tree appearance. Right? So there are typical appearances which are seen. One, we discussed, there is beaded appearance. Second, there is pseudo diverticular appearance, and there is pruned tree appearance. Right? Since intrahepatic bile duct is also involved here, obviously the treatment of choice is liver transplantation. But in many patients, what? They are waiting for liver transplantation because what? The donor is not available. So if the donor is not available, to control inflammation, we are giving high dose ursodeoxycholic acid, UDCA, high dose ursodeoxycholic acid. And since these patients are having itching also, right, pruritus also, so to take care of pruritus, we are giving what? Cholestyramine or cholestyramine, which are bile acid sequestrants, right? So see the management. The treatment of choice is liver transplantation. We give high dose ursodeoxycholic acid to control inflammation, and bile acid sequestrants like cholestyramine or cholestyramine. Clear? These are given. Why? For the pruritus. Now we are going to discuss bile duct injury, and nowadays this is frequently asked in exam. Bile duct injury. Okay, so incidence of bile duct injury is more in open cholecystectomy or lap cholecystectomy. Obviously it's more in lap cholecystectomy. See the incidence of bile duct injury. So if you see the open cholecystectomy, in open cholecystectomy, what's the incidence? It's 0.1 to 0.2%. And if we see the lap cholecystectomy, the incidence is 0.3 to 0.85%. So obviously it is more in lap cholecystectomy. Question is frequently asked that during lap cholecystectomy, which part of bile duct is most commonly injured? Before that, you have to see this diagram. So the two questions which are frequently asked in exams as well as in viva, one is Callott's triangle and one is hepatocystic triangle or triangle of cholecystectomy. So see, if you see this diagram, you can make out that this is what left hepatic duct and this is what right hepatic duct. Both left hepatic duct and right hepatic duct are going to join and form what? Common hepatic duct. So this is common hepatic duct. Here you can see this is what? Cystic duct, and you can see this is which artery? This is cystic artery, right? And here you can see that there is a triangle. Clear? So this triangle is known as Callott's triangle, and you can see the boundaries: medially lateral wall of common hepatic duct, inferiorly cystic duct, and superiorly cystic artery. This is Callott's triangle. And if you see this triangle, this bigger one, if you see this triangle, this is hepatocystic triangle, also known as triangle of cholecystectomy. Here common hepatic duct and cystic duct, these are the two common boundaries. But if you see the superiorly, if you see superiorly, there is inferior liver edge. So what are the boundaries here? In triangle of cholecystectomy, which is also known as hepatocystic triangle, right? Here superiorly there is inferior liver edge, inferior liver edge, right? After that, two more questions are asked. What is the content of Callott's triangle? So there is a lymph node here, there is a lymph node, and what's the name of this lymph node? This is known as lymph node of Lund, also known as cystic lymph node or lymph node of Lund. So what is the content of Callott's triangle? Lymph node of Lund. And if you see the content of hepatocystic triangle, this is the content. And what is that? That's cystic artery. So cystic artery is the content of hepatocystic triangle, and the lymph node of Lund is the content of Callott's triangle. Simple. If I'm going to perform the cholecystectomy, so obviously which part of bile duct is most commonly injured? You tell me, this proximal part or this distal part? So obviously proximal part. In proximal part, particularly which part? Obviously it's the common hepatic duct. And in common hepatic duct, which wall? Lateral or medial? So obviously it's which wall? It's this. Yes, the lateral wall. So most commonly injured part of bile duct in lap cholecystectomy, proximal part or lateral wall of common hepatic duct. So most commonly injured is proximal part of bile duct, specifically is the lateral wall of common hepatic duct. There are two classification systems which are asked related to injury and strictures. If suppose some kind of bile duct injury is going to occur, obviously the injury is going to heal with the formation of stricture. So there is a classification known as Bismuth classification of biliary strictures. And there is a classification for laparoscopic bile duct injuries, that is Strasberg classification. Both of these are frequently asked. We are going to discuss one by one. First, Bismuth classification. Bismuth classification for biliary strictures. Okay, now see, whenever we are doing laparoscopic cholecystectomy, see, suppose this is the common hepatic duct, right? And you are doing laparoscopic cholecystectomy, and what happens? There is injury to this part of common hepatic duct. So here you can see the common hepatic duct stump is more than 2 centimeter. And when it is more than 2 centimeter, the stricture is low. This is known as type 1. If the injury is here, then stricture is here, and here common hepatic duct stump is less than 2 centimeter. This is type 2. If injury is here, what? Hilar stricture, but you can see the confluence is intact. What do you mean by confluence? It's the where confluence means where right hepatic duct and left hepatic duct, both of these are going to join together. Clear? So the confluence is intact. This is type 3 hilar stricture with intact confluence. Be careful, if the stricture is here, injury is here, so stricture is here, hilar strictures with destroyed confluence, that is type 4, and there is type 5 also. So what are these types? One by one. This is type 1, where this common hepatic duct stump is more than 2 centimeter. Clear? So the stricture is low. In this case, this is type 2. Here you can see common hepatic duct stump is less than 2 centimeter, so stricture is mid. Here you can see hilar stricture with intact confluence, and this is type 3. This is hilar stricture with intact confluence. Intact confluence, right? And what's type 4? It's the hilar stricture with destroyed confluence. Type 4, that's hilar stricture with destroyed confluence, right? To understand type 5, you have to understand anatomy, and that's very easy to understand. See, so if you see this diagram, yes, this is the liver here, this is the bile duct. You can see this is left hepatic duct and this is right hepatic duct. How this right hepatic duct is formed? You can see there are sectoral duct. We discussed in the liver that in right lobe of liver there is anterior sector and there is posterior sector. In anterior sector, which segments are located? 5 and 8. In posterior sector, there is 6 and 7. So anterior sector is having a duct known as anterior sectoral duct. Posterior sector is also having a duct known as posterior sectoral duct. When anterior and posterior sectoral duct is going to join, what? This right hepatic duct is formed. When right joins with left, there is common hepatic duct, and when cystic duct is going to join common hepatic duct, what? This is CBD. Now see, this is anterior sectoral duct. So what? This anterior sectoral duct is aberrant. Aberrant means abnormal origin or abnormal insertion. So rather than joining here, what? This sectoral duct is going to join what? Cystic duct. So when this sectoral duct is going to join cystic duct or common hepatic duct, this is aberrant, and it's very prone to get injured during lap cholecystectomy. So suppose it is injured, and when it is injured, there is formation of stricture. So stricture involving aberrant right sectoral duct with or without stricture of common hepatic duct, that's type 5. So what's type 5? Is the stricture involving aberrant right sectoral duct, aberrant right sectoral duct with or without stricture of common hepatic duct, with or without stricture of common hepatic duct. So these are 5 types. What is the biggest problem of this classification? That there is no information related to type of injury, how injury occurred, and whether there was bile leak or not. That's why there is a better classification which is used, and that's Strasbourg classification. So what's the Strasbourg classification? So this is for laparoscopic bile duct injury. That was for strictures. This is for injuries. Okay. Now it's very easy to understand. Suppose in a patient we are going to perform the lap cholecystectomy. So this is the patient, this is the cystic duct, this is a gallbladder. Okay, whenever we are performing lap cholecystectomy, we are going to apply 2 clips towards cystic duct side, 1 clip towards gallbladder side, and what we are going to remove the gallbladder. When you excise the gallbladder, what's the final diagram? This is the final diagram. So what you are left with? You are left with cystic duct stump and structure like this. The clips are being applied at cystic duct stump. Now whenever we are performing lap cholecystectomy, during handling of gallbladder, suppose there is a small stone and that small stone slips and now it comes into CBD. So the small stone slips and comes into CBD. What is the problem? Now stone is in the CBD and I'm not aware that there is a stone. What will happen in post-operative period? Because of this stone in CBD, there is increased pressure. And because of this increased pressure, what will happen? The clips are dislodged. So here you can see the clips are dislodged, and if the clips are dislodged, what you notice that there is bile leak from cystic duct stump, and this is the most common type known as type A. This is only one part. There is one duct known as subvesical duct of Lashka. It's a minor duct which is attached to the gallbladder. Okay, so whenever this minor duct is injured during lap cholecystectomy, again there is bile leak. So both of these are included in type A, which is the most common type, right? So what's type A? Is the cystic duct stump leak or leak from subvesical duct of Lashka. This is most common type, right? Now what is type B? Okay, we discussed just now that there is aberrant right sectoral duct. This was the diagram. This is posterior sectoral duct, and suppose this is anterior sectoral duct. This is aberrant. Now there is high risk of injury. So see what, during surgery, if I'm going to apply the clip, before cutting this structure, if I'm going to apply the clip, that is transection with occlusion. So this is known as type B. And see, if I'm going to divide this without applying a clip, so this is transection without occlusion. So this is type C. So what is type B? Is the transection with occlusion of aberrant right sectoral duct. And what's type C? It's transection without occlusion of aberrant right sectoral duct. Now see what is type D. Type D is lateral injury. Here is the injury. So lateral injury to common hepatic duct. So type D, and that's lateral injury to common hepatic duct. And what is type E? Type E is nothing. It's the E1 to E5 bismuth classification. So what's type E? It's E1 to E5 bismuth classification. So here you can see in type A of Strasbourg classification, there is cystic duct stump leak or leak from subvesical duct of Lashka. In type B, there is transection with occlusion of aberrant right sectoral duct. Type C, transection without occlusion of aberrant right sectoral duct. Type D, lateral injury to common hepatic duct. Type E, E1 to E5 bismuth classification. So E1, common hepatic duct stump is more than 2 cm. E2, less than 2 cm. E3, hilar stricture with intact confluence, can you see? And here, hilar stricture with destroyed confluence, E4. And E5, stricture involving aberrant right sectoral duct, with or without stricture of common hepatic duct. So both of these are very, very important. You have to remember. Now see how we are going to manage post-operatively diagnosed case of bile duct injury. Means suppose laparoscopic cholecystectomy was done and bile duct was injured. Surgeon was not aware that bile duct was injured. What will happen in post-operative period? You have seen in the wards in post-operative period when the surgeon is coming for the rounds, what the surgeon is doing, first the surgeon is taking the pulse of patient. If pulse is settled, most of the things are settled. If patient is having tachycardia, this might be an indirect evidence of what? Bile leak, right? So if patient is having tachycardia, next step is the surgeon is going to start the palpation. Since the lap cholecystectomy is done, so first we have to start palpation from non-tender area. So I will start palpation from this left iliac fossa, and then in the last I'm going to palpate this right hypochondrium. When I'm going to palpate right hypochondrium, I'm going to find that there is tenderness. So 2 findings: there is tachycardia and there is tenderness. So I suspect that there might be what? Bile duct injury. So I ask my resident to start IV antibiotics. So first step, start antibiotics and then send this patient for ultrasound. On ultrasound, what? Whether there is any collection or not. So if there is any collection because of bile leak, what? You have to drain it. So either ultrasound or CT guided percutaneous aspiration, or you have to insert drain or pigtail catheter. So first step, control the infection by antibiotics. Second step, drain the biloma. Ultrasound or CT guided percutaneous aspiration or drain insertion. Third step, complete the cholangiography. So we have to perform the cholangiography to see that what's the site of injury. And fourth step is definitive intervention. So we can insert the stent if there is stricture, or we can go for Roux-en-Y hepaticojejunostomy. So this is how we manage the patient. So steps of management. What are the steps of management of post-operatively diagnosed bile duct injury? Okay, so first step, control the infection, right? So how we control the infection? Start IV antibiotics. Clear? Second step, drain the biloma. Drain the biloma. And how we are going to drain? Two options: easiest, ultrasound or CT guided percutaneous aspiration, or pigtail catheter insertion, or drain insertion, right? What's the third step? Complete the cholangiography. So we perform MRCP to see the site of stricture. Complete the cholangiography. So we perform what? MRCP. And the fourth step is definitive intervention. Fourth, definitive intervention. And there are two options. If there is stricture, yes, which is possible, we can go for ERCP with stenting. If it's not possible, we can go for Roux-en-Y hepaticojejunostomy. Now see, this is the favorite topic of AIMS people. If you have seen the paper of AIMS from last 3-4 years, 2 to 3 times this question was asked indirectly. They give a clinical scenario and then they ask the question. Now what's the clinical scenario? See, a patient of bile duct injury. In a patient of bile duct injury, now see, this is the patient. In a patient of bile duct injury, drain was inserted. So suppose this is the site of injury and drain was inserted. This is the drain, right? So what will be the problem? See, here the bile will start coming out like this. The first day drain output was 100 ml, second day was 100, 200, 200, 200, 250, 200, 250. So almost the drain output is maintained between 200 to 250. It is not decreasing. In majority of cases, you will notice what? That over a period of time, the output is going to decrease. Why? Because bile is going to follow the normal path. So bile is going to follow the normal path. It will start going into duodenum and the injury site is going to heal. But here what's the problem? The drain output is increasing or it's constant. Why? Because there is obstruction. And if there is obstruction, obviously this bile will not follow the natural path and bile will start coming out. That's why drain output is almost constant. So the question, in post-operatively diagnosed case of bile duct injury, when drain output is decreasing, what's the next best step? Nothing. Observation, because it will heal. And if it's increasing or if it's continuous, constant, then we go for ERCP with stenting. Clear? So these are the clinical questions which are asked in AIIMS related to bile duct injury. Now we are going to discuss cholangiocarcinoma. First of all, have a look of risk factors for cholangiocarcinoma. So what are the risk factors? Risk factors for cholangiocarcinoma. Okay, so first of all, choledochal cyst. So it's choledochal cyst. Second, choledocholithiasis or CBD stone. Primary sclerosing cholangitis, ulcerative colitis, cirrhosis, and worms. Here which worms? Clonorchis sinensis and Opistorchis viverni. So which worms? Clonorchis sinensis and Opistorchis viverni. Clear? What are the other risk factors? Hepatitis B virus, HIV, hepatitis C virus infection, asbestos, nitrosamines, dioxin, and diabetes mellitus, obesity, OCPs, smoking, thorotrust, and isoniazid. Clear? So this list is very long, but this is frequently asked in PGI Chandigarh. So how to remember? Can you see? This is C, 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 C. So what? 6C. Here you can see BHC. So this is what? BHC. What is this? And can you see what is this? Dosti. So 6C, BHC, and Dosti. Yes, highly illogical mnemonic but helpful in remembering the risk factors. So these are the risk factors for cholangiocarcinoma. Now see what is the most common site of cholangiocarcinoma. It's hilum. So this is hilum. So the most common site of cholangiocarcinoma is this hilum. Okay, and hilar cholangiocarcinomas are known as Klatskin tumor. So this is hilar cholangio, and what's the other name? This is Klatskin tumor. When I was discussing gallbladder, we discussed that there are many similarities between carcinoma gallbladder and cholangiocarcinoma. What is the first similarity? That both are adenocarcinoma, and there is a non-specific marker raised for both, and that is CEA. What is the specific marker? That is CA99. What is the chemotherapy regimen? That is gemcitabine plus cisplatin, and the histological types are also same. So see the similarities between carcinoma gallbladder and cholangio. Both are adenocarcinoma. What's the non-specific tumor marker for both? And that's CEA. What's the specific tumor marker? Specific tumor marker for both, and that's CA99. What's the chemotherapy regimen, and that is gemcitabine plus cisplatin. Clear? And histological types are also same. So what are the histological types? First is diffuse infiltrative, also known as diffuse sclerosing. Second is nodular or mass forming, and third is papillary. Right? Out of these three, which one is most common having worst prognosis? It's this one, most common having worst prognosis. And out of these three, which one is having best prognosis? Obviously papillary. Clear? Now coming to clinical features, it's very easy to remember the symptoms. See, this is the patient who is having cholangiocarcinoma, right? See, now this patient is having cholangiocarcinoma. Can you see the growth? So this kind of growth is there, and slowly the lumen is getting obstructed. So what is the most common symptom? Jaundice followed by weight loss. What kind of jaundice? There is painless progressive jaundice. See, painless progressive jaundice is seen in cholangiocarcinoma and early stages of carcinoma pancreas. In carcinoma pancreas, the jaundice is painless only initially. Later, it becomes painful. So typically, painless progressive jaundice is seen in cholangiocarcinoma. So the most common symptom is jaundice followed by weight loss. It's jaundice followed by weight loss. What kind of jaundice? It's painless progressive jaundice. Now see, whenever there is obstructive jaundice, there are certain complementary symptoms. Since there is obstruction, this patient is going to pass clay colored stools. Because of this obstructive jaundice, what's the problem? There is deposition of bile salts near nerve endings, so patient is having pruritus, and patient is having anorexia and fatigue. So these are complementary symptoms. So what are the other symptoms? There is pruritus, there is passage of clay colored stools, there is anorexia and fatigue. Okay, one question which is asked frequently, that in patients of cholangiocarcinoma, in majority of cases, gallbladder is palpable or it's non-palpable. Okay, see, so here you can notice that in majority of cases, the malignancy is located at hilum. It means it's proximal to gallbladder. So in these cases, obviously the gallbladder is not palpable. Now see, this simple logic is applicable for any tubular structure. Any hollow or tubular structure like CBD, ureter and GIT. So what's that principle? Imagine that this is a tubular structure, and in this tubular structure, here is the obstruction. So whatever the segment which is proximal to obstruction, that will be distended, and whatever the segment which is distal, that will be collapsed. So proximal segment is distended and distal is collapsed. So here you notice that if a patient is having periampullary carcinoma, in this case the proximal part will be distended, and in that case you are going to find a palpable gallbladder. So what's the name of this law? This is Courvoisier's law. So what is Courvoisier's law? In a case of obstructive jaundice, gallbladder is seldom palpable due to stone disease. So see, Courvoisier's law. In a case of obstructive jaundice, gallbladder is seldom palpable, rarely palpable, seldom palpable due to stone disease. So why? Because if there is stone, because of stone there is chronic inflammation, and because of this chronic inflammation there is fibrosis, and because of this fibrosis there is contraction. So what happens? The gallbladder is shriveled or fibrosed. So because of stone, it's not palpable, it is actually shriveled, or fibrosed. Clear? This is not the actual meaning of Courvoisier's law. What is the actual meaning of Courvoisier's law? That in case of obstructive jaundice, gallbladder is palpable in periampullary carcinoma. Clear? So, in a case of obstructive jaundice, if gallbladder is palpable, it's due to periampullary carcinoma. Clear? This is the actual meaning. Now, what are the exceptions of Courvoisier's law? So, for exceptions, there should be presence of stone and the gallbladder should be palpable. So, what's that? See, this is liver, this is gallbladder, this is cystic duct, this is CBD. So, first exception is double impaction of stone. Can you see? So, one stone in cystic duct and one in CBD. So, what are the exceptions of Courvoisier's law? Exceptions. So first is double impaction of stone. Double impaction of stone. Okay. One in cystic duct, one in CBD. Second, mucocele. Third, oriental cholangiohepatitis, also known as hepatolithiasis. Oriental cholangiohepatitis, also known as hepatolithiasis. And fourth, stone impacted at ampulla of Vater. Okay, so stone impacted at ampulla of Vater. These are the exceptions of Courvoisier's law. Certain students are confused between ampullary and periampullary carcinoma, and some of the students are thinking that both are same. No, both are not same. See, in surgery, if you have difficulty in remembering something, you have to do the dissection or surgery of that term. So if we are going to discuss ampullary, means the malignancy arising directly from ampulla, and if periampullary, if we are going to discuss periampullary, peri means around ampulla, means within 2 centimeter of ampulla. So see what this periampullary carcinoma includes. So this is liver, this is gallbladder, this is bile duct, and this is duodenum. If the malignancy is arising directly from ampulla, this is ampullary, and if the malignancy is arising within 2 centimeter of ampulla, this is periampullary. So what are the malignancies? So here you can see the malignancies arising within 2 centimeter of ampulla. So periampullary carcinoma. It includes first ampullary carcinoma, second carcinoma head of pancreas, third is distal cholangiocarcinoma, and fourth is duodenal carcinoma. Is the duodenal carcinoma, right? Now, out of these 4, which one is having worst prognosis, which one is having best prognosis? So the malignancy which is outside of hepatobiliary pancreatic tract, which is totally different, that is having best prognosis. So you can see this duodenal carcinoma, it's intestinal malignancy, so this one is having best prognosis. So duodenal carcinoma, this is having best prognosis. Clear? And out of these 3, ampullary carcinoma head of pancreas, distal cholangio, which is having worst prognosis, carcinoma head of pancreas. Clear? So this is having worse prognosis. So if a question is asked indirectly that in which type of cholangiocarcinoma gallbladder is palpable, so obviously it's the distal cholangio. Otherwise, in majority of cases of cholangiocarcinoma, gallbladder is non-palpable. Now coming to the diagnosis, we discussed what's the investigation of choice. For diagnosis, this is MRI plus MRCP, right? Sometimes examiners are going to ask you that you want to go for CCT or MRI plus MRCP, which one is better? So obviously it's MRI plus MRCP which is better than CCT. So why? See, in contrast enhanced CT, what you give? You give contrast. Clear? And you know that in patients of obstructive jaundice, there is risk of hepatorenal syndrome. That's why we have to keep urine output more than 2.5 liter, and we have to maintain the hydration status of the patient. So if we give contrast, there are chances that patient is going to develop contrast induced nephropathy, renal failure, or it can precipitate hepatorenal syndrome. So theoretically, which one is better? MRI plus MRCP is better. Suppose this option is not there in the exam, then you can go for CCT. Now coming to management. So what's the treatment of hilar cholangiocarcinoma? See, so malignancy is located at hilum. When we were discussing the liver, we discussed that caudate lobe, it gives its biliary drainage to both right and left hepatic duct. That's why in hilar cholangiocarcinoma there is early involvement of caudate lobe. So that's why in hilar cholangiocarcinoma we go for routine caudate lobectomy. Okay. So what's the treatment for hilar cholangio? So for hilar cholangio we go for CBD resection plus lymphadenectomy plus routine caudate lobectomy. Routine caudate lobectomy. Clear? And if the patient is having distal cholangio, in that case we go for pylorus preserving Whipple's procedure, also known as pylorus preserving pancreaticoduodenectomy. So we go for pylorus preserving Whipple's procedure. So this is how we manage or we treat the cholangiocarcinoma. And some patients are coming with metastasis. So if patient is having advanced stage or metastasis, so in those cases we go for palliation. And what is the chemotherapy which is given for palliation? For palliation we give gemcitabine plus cisplatin. Next important topic is hemobilia. So what is hemobilia? See, this is hemo and this is bilia. So it's very easy to understand. See what's happening here. This is happening. So you can see that there is an arrow. You must be thinking that, sir, this is arrow of Amazon. This is not the arrow of Amazon. This is Amazon, not Amazon arrow. This is arrow of hemobilia. So you can see what's happening. Hemo means blood is going into bile duct. That's hemobilia. So how blood started going into bile duct? Because you did some kind of injury. So which intervention you were performing or doing during that you did the injury? You were performing percutaneous transhepatic cholangiography. And during this percutaneous transhepatic cholangiography, some small vessel was injured and that artery or vessel started bleeding into the bile duct. Because of that there is hemobilia. Right? So first, what's the most common cause? It's iatrogenic. So during which intervention? It's during percutaneous transhepatic cholangiography. What are the other causes? This is the most common cause. It is caused by trauma. Which kind of? Blunt trauma. It can be caused by gallstones. It can be seen in vascular malformations. In cases of vascular malformations. Okay, it's very easy to understand. See what's happening here. This is liver. Okay, this is the bile duct, right? This is intrahepatic bile duct. Now see, when you perform the PTC, some minor vessel was injured and that vessel started bleeding. So what will happen? Can you see? The blood starts going like this and it's going into duodenum. So see, the blood is going like this into duodenum. Okay, so when the blood is going into duodenum, it fits minor bleeding. Yes, it can manifest as melena, and if it's massive bleeding, it can manifest as what? Hematemesis. Second, whatever the blood is going into the bile duct, it might clot. And if the blood is going to clot, what will happen? There is clot colic, and because of this obstruction, there is jaundice. So what? There is GI bleeding, upper GI or lower GI, plus clot colic, plus jaundice. The name of this triad is Quink's triad or Sandblom's triad, right? So, clinical features, it is characterized by Quink's triad or Sandblom's triad, right? What are the components? It is characterized by clot colic, jaundice, and GI hemorrhage. What kind of? Upper GI or lower GI? Upper GI means it can lead to hematemesis, clear? And lower GI means it can lead to melena. Now see, out of clot colic, jaundice, hematemesis, melena, which one is the most common symptom? It will be seen in almost all patients. So in more than 90% patients, what you are going to find the melena. So the most common symptom is melena, right? And this question was asked many times in DNB, that how much minimum bleeding is required for melena. Range is 40 to 60 ml, but in the exam they asked one value, and that was 60 ml. So how much bleeding? 40 to 60 ml. This is for melena. Now in this case, since there is bleeding, what is the first investigation done? The first investigation done is upper GI endoscopy. The source of bleeding in majority of cases is arterial. So if the source of bleeding in majority of cases is arterial, what is the investigation which is both diagnostic and therapeutic? And that's angiography, because angiography will tell you that what is the source of bleeding, and by embolization you can control the bleeding. So two questions which are asked in diagnosis: what is the first investigation done? That is endoscopy, upper GI endoscopy. And what is the investigation of choice for diagnosis? And that is angiography. What is the advantage of angiography? That it is both diagnostic and therapeutic. What is the good thing in patients of hemophilia? That in majority of cases a minor vessel is injured and the bleeding stops spontaneously. So what? Conservative management is sufficient in majority of cases. But if bleeding is not stopped spontaneously, we have to go for angiography with embolization. So you go for angiography with embolization. If angiography is not available or embolization is failed, in that case we can go for open surgical ligation. So management in majority of cases, what? Conservative management. If patient is not responding, so we can go for angiography plus embolization. If it's not available or failed, we go for what? Open surgical ligation of bleeding vessel. So this is how we manage the patients of hemophilia, and this is all about bile duct.